Okay, good morning everyone. La- So today we are going to talk about nasal polypi, right? Like epistaxis and like other topics, this is also a very important topic. And questions regarding nasal polyps, they may be asked in your theory exam or in your practical exams. So be assured that you'll always have one question regarding nasal polypi. The good thing about nasal polypi is that this is a comparatively a very easy topic. Okay, so let us talk something about nasal polyps. So you must have heard about this word very often, and till now you may have assumed that anything that is coming in the nose, coming out from the nose, or that is in the nose is a nasal polyp. We frequently get cases referred from periphery by HS, CMS, or other health practitioner, and there is a mass in the nasal cavity, which is a normal mass, but it has been wrongly said is nasal polyp. The good thing is that okay, they have referred the patient to the higher center, but the worst thing is that they have attempted treatment for over several months, but people they do not understand that this is a normal thing and this doesn't need to be treated. So nasal polypi is frequently misunderstood as different other diseases, and it is frequently misdiagnosed. Most often, it is overdiagnosed. Okay, so that is what I meant by saying even normal masses they have been labeled as nasal polypi. So this topic is important for you. Is you must be able to differentiate other masses from nasal polyps. Okay, so let us go to the next slide. So the definition is very important, and when I was doing my residency, my professor, like it was his favorite question to ask the MPPS students during their examination time in the practicals define nasal polyp. So there are different definitions, okay, but the gist of all the definitions they are more or less similar. So hypertrophied, edematous, prolapsed mucosa of nose and paranasal sinuses. Okay, it is nothing else, but it is the mucosa of the nose and paranasal sinuses. And look here, there are a few terms. Hypertrophied. Okay, normally mucosa is attached to the inner structures. Okay, but here it is hypertrophied, and then it becomes edematous. Similarly, it is prolapsing. It is protruding. If it is not protruding, then it is not a polyp. It should be protruding, either going behind or either coming outside. Okay, so this is from your book from Dingra. Okay, nasal polyp is non-neoplastic, pedunculated, edematous, prolapsed respiratory mucosa of nose and sinuses. Okay, so nearly the same definition. Okay, or nasal polyposis can be defined as chronic inflammatory disease of the paranasal sinus mucosa leading to a protrusion of benign edematous polyps from meatus into the nasal cavities. Okay, mostly the terms they are similar everywhere. Protrusion, okay, prolapsed, all right. It should be edematous, all right, and it is benign or non-neoplastic. Okay. Now the properties of nasal polyp. So why you need to know this, the properties? Because you need to differentiate it from other swellings or other masses in the nasal cavity. Okay, it is gray in color. It is gray in color. Okay. Okay. Enlarged inferior turbinate is also a very common condition. Okay, you frequently get to see patients who come with the complaint of a mass in the nasal cavity. And when you examine the patient, you find that it is only a hypertrophied inferior turbinate. So the color helps you to differentiate between the normal mass like the inferior turbinate and this nasal polyp. The nasal polyp is not pinkish, it is gray in color. It is glistening because it matters, it is shining, and when you use a light, so it shines. It has a smooth surface and it is pedunculated. So when you touch it, okay, there is a test called probe test. Okay, I'll have to tell you this because usually we tell this to the students in the clinical posting, but because you are not having clinical postings, so we'll also talk something about the clinical methods of ENT. So whenever we are examining the nose of the patient, what we do is first we inspect the external nose. Okay, the first point is inspection. Okay, in the inspection we look for the osteocartilaginous framework of the nose. Then we look for any scar mark, any swelling. Okay, there can be dermoid, there can be meningoencephalocele. Okay, there can be different swelling, and there can be scar mark from previous surgeries. Okay, nasolabial angle, nasolabial fold. Okay, and similarly the color of the skin. So these things we look in the inspection. So once the inspection of the nose is completed, so what you do is you check for the patency. So patency means, okay, something is patent if it is not obstructed. So because nose is, the function of the nose is to take the air inside, so any obstruction will compromise the function of the nose. So we need to check for the patency so as to rule out any obstruction. So what we do is, there are many methods to check out patency. Okay, so there is one pulley spatula test. What you do is you take the tongue depressor, which is cold, and you put it below the nose, and the patient breathes out and breathes in the normal way, and then you see for the misting, because the spatula, the metallic spatula, is cold, and the air that we exhale is warm, so there will be humidification, and if there is enough misting, okay, or condensation, so it means the nasal cavities are patent. Similarly, you can use a small foil of paper and put it below the nose. So if the patient is, if the nasal cavities they are patent, so it will be moving, they will move. And there's several other methods. Maybe later on, after everything is over, I'll show you. I'll take a class on the clinical methods. But the clinical methods, it is better to be shown than explained. Okay. And after patency, what we do is, there is one test called the vestibular examination. We leave the tip of the nose, and then we look for the litmus area, we look for caudal dislocation of the septum, we look for vestibulitis, we look for furunculasis, these conditions, okay? And after this, we have a test called anterior rhinoscopy. In the anterior rhinoscopy, what we do is, we use a venous nasal speculum or thuricum. We do not use Killian's nasal speculum. Killian's nasal speculum and venous nasal speculum, they look quite similar. But the difference is that Killian's nasal speculum, it has a self-retaining straw. So it is only used in the operation theater. In the OPD, we use venous nasal speculum. So we put the speculum inside the nose, and we retract it, and we try to see the inner structures like the roof, the floor, the middle wall, and the lateral wall. Okay. So what we do not see by vestibular examination, by lifting the tip of the nose, we see by interrhinoscopy using the speculum. But if the patient has vestibulitis, if the patient has furunculosis, you do not do the interrhinoscopy. You do not put inside the speculum, because it is a very painful condition and the patient will jump with pain. Okay, similarly, you must always do vestibular examination so as to see the litmus area and the status of the septum. So when doing anterior rhinoscopy using the speculum, if we see some, if we see a mass, so we do a probe test. We take a probe and we look for the sensitivity of that mass. We look for the mobility. We look for the bleeding tendency of that mass. All of these things we do in the probe test. Okay, and after the probe test is over, then what we do is posterior rhinoscopy. Okay, we put a mirror in the oropharynx and try to look for the nasopharynx. Okay, so the polyps, they are insensitive to pain, and anything inferior turbinate which may be confused with nasal polyp is sensitive to pain. Similarly, it is mobile. Okay, and the nasal polyp, they do not bleed in probing, but if it is a malignant condition or if it is angiofibroma, in angiofibroma you must never do any probing. Okay, so what I mean to say is that there are other conditions that bleed when you probe them, but not polyp. Okay, so you may be knowing that there are two types of polyp. One is maxillary sinus polyp, and then there is another ethmoid polyp. So maxillary sinus polyp is also called as enterochoanal polyp. Okay, so this is the lateral nasal view, and Okay, this inferior turbinate, no, this is the inferior turbinate and inferior meatus, and this is the middle turbinate and middle meatus, and the maxillary sinus is lateral to this part. And see the mass, it is coming from the maxillary sinus and it is coming towards the choana, and not only in the choana, but it has reached in the nasopharynx. Okay, this part, the inferior ends of the turbinate or the opening of the nasal cavity is the posterior choana. Okay, so by now you know where it's located, but see this mass, it has been crossing the choana into the nasopharynx, and sometimes when it is large, it can come below this soft. This is the soft palate. Okay, so this can come, this can protrude even from here. Okay, and you can see it in the oropharynx. So there are these two types of nasal polyps, and we need to be able to differentiate well between these polyps because the management is quite different. Right? So the patient, they usually come to you with complaint of nasal obstruction. Okay, this slide is also a very important slide, and you do not have to write it down because this has been lifted from Jingra. Okay, so you may be asked about, and this is also a very common question, especially in the practical exams, in the Viva, and sometimes in the theory exams too. You may be asked, what are the common causes for unilateral nasal obstruction, and what are the common causes for bilateral nasal obstruction? So now you're already in 4th year, and you need to know anything that is in the box and the diagrams. They're important. That is why they are in the boxes. Okay, so obstruction can occur anywhere in the vestibule, in the nasal cavity, and in the nasopharynx, right? So in the vestibule, it could be due to furuncle or vestibulitis, stenosis of the nares, atresia, nasoalveolar cyst. Okay, this is not a very common condition. And similar papilloma and squamous cell carcinoma. Okay, and this is very common. Okay, so these things, they can be seen from outside and can easily be diagnosed. And nasal cavity. Okay, the conditions in the nasal cavity is in MBBS students, you need to suspect or make a provincial diagnosis of some of these conditions. Okay, in the nasal cavity, it could be due to foreign body. It could be due to deviated nasal septum. It could be due to hypertrophic turbinates. It could be due to concabulosa. It could be due to enterocorneal polyp, which is what we are going to talk about. It could be due to synechia or rhinolith, bleeding polypus of septum, benign and malignant tumors of nose and pharyngeal sinuses, sinusitis, and unilateral choanal atresia in nasopharynx. Okay. Similarly, there are other conditions in the nose which cause bilateral obstruction. Okay. So you need to be, so whenever the patient has unilateral obstruction, you need to differentiate between, you need to know that the obstruction is due to foreign body, but not DNS. Okay, the obstruction is due to AC polyp, not bleeding polypus of the septum. Okay, so at the end of your ENT classes, you should be able to make a provisional diagnosis. Okay, so here I have kept this in a box. So AC polyp or intracorneal polyp, it almost always causes unilateral nasal obstruction, and when the patient is having bilateral obstruction, you never suspect AC polyp. Okay, you suspect nasal polypi or ethmoidal polyps. Okay. Okay, I'm going to skip all these diseases because we have studied about a few of them in the previous classes, and other diseases, okay, like the septal hematoma, F.E.S.S, and these things we have already studied, and some other topics we are going to study later on. Okay, so before we go deeper into the topic, I need to give you an overview of the nasal cavity. Okay, so this is the vestibule. So obstruction may occur here, and in the nasal cavity, the obstruction may occur here. Okay, inferior turbinate, middle turbinate, and superior turbinate, and their corresponding meatus. So this is the atrium, and this is the agar nasa, the innermost ethmoidal cell. Okay, so now let us go to the AC polyp. So what is the clinical presentation like? Okay, so this is very important. In ENT diseases, the history and clinical examination will help you to diagnose a lot of conditions. So the patient is usually adolescent or child, and there is almost always unilateral nasal obstruction, and because of the obstruction there is unilateral nasal discharge. Now, so this is important. So what are the differential diagnoses? As an MBBS student, you must always be able to diagnose enterocorneal polyp and separate it or differentiate it from these conditions. Okay, hypertrophic inferior turbinate. How do you differentiate? Because it has the color of the mucosa. It is pinkish in color. Okay, and it is coming from the lateral wall. Okay, and the color and it is sensitive to touch, and it may bleed on touch if you poke it. A blob of mucus. Okay, the color is similar. So how do you differentiate it? So you differentiate it by the suction. Okay, when you do the suction, the blob of mucosa will be pulled inside the suction machine, but the AC polyp won't be. So inverted papilloma. So the inverted papilloma, it may become difficult for you to diagnose it, right? But when the color are different and it may bleed on touch, right? So this is an intermediate condition. It is not a benign, not a malignant condition, intermediate condition, okay? And most always we can diagnose it by only histopathology. Similarly, rhinosporidisis and rhinoscleroma, okay, these conditions and the papilloma, they are quite similar, okay, and the diagnosis by histopathology. So angiofibroma, okay, it is again in adolescence, and there is a history of bleeding, but AC polyp, it won't bleed, okay, and you do not do any probing or biopsy in the angiofibroma. Similarly, meningocele and the malignancy. So we already have talked about meningocele. So meningocele, it will increase by coughing. So that is how you can clinically differentiate between these conditions. And in malignancy, so it is ulcerative proliferative lesion and it looks quite different from enterocorneal polyp. So look here, there is a nasal mass protruding from the right nasal cavity. Okay, and on the oropharyngeal examination, you see something protruding down from the inside the oropharynx. Okay, so this can be AC polyp. This can be the choanal part of the AC polyp. So it has grown out into the nasopharynx and up to the oropharynx. Sometimes the patient, you won't be able to see anything in the nasal cavity, but when you see the mouth, you see these things, and this is quite common. Okay, another mass. Okay, so this is the choanal part of the AC polyp. Look how it has grown into the oropharynx. Okay, on the posterior rhinoscopy, this is what we see. Now, examination of the nasal mass. Okay, whenever there is a nasal mass, you need to inspect. You need to mention the side. Is it in the right side or left side? Laterality is very important. And size, how big, and the number, color, surface, is it pedunculate, sessile, origin, or attached. So you do this in any mass which is not angiofibroma. Okay, and the probing is done. So I already told you about probing. So it is done to find out consistency, sensitivity to touch, bleeding or touch, and if it can be passed all around or not. Okay, so that is the importance of sensitivity. So you may be asked, why do you do the probe test or probing? So to look for the sensitivity, okay, to look for the consistency. Now, how will probe test differentiate between AC polyp and hypertrophic turbinate? Okay, after you finish the class, you may feel that, okay, why do you even need to differentiate between these two things? But there are so many patients, they are sent to the OPD with hypertrophic turbinate, and they have been told that it is a mass that requires operation, and it becomes very difficult for us to counsel the patient that, okay, no, this is not a pathological mass and this doesn't need to be treated, okay, and you do not worry. So whenever you're in the periphery, so do not counsel the patient for any for the operation, okay. So they usually tend to believe their local practitioners a lot, and when we tell them that, okay, it is not any AC polyp or any other pathological mass, so it becomes a difficult task for us to make them understand, okay. So AC polyp is insensitive to pain, but this is sensitive to pain, okay. The probe can be passed all around, okay, but because this turbinate, it is coming from the lateral wall, okay, and it is a bone with the mucus, mucosa. So it cannot be, the probe cannot be passed all around because of the attachment to the lateral wall. Similarly, this is mobile, but this is fixed to the lateral wall. Now, etiology and origin. Sometimes you can be asked this, okay? So etiology, the etiology is mostly infective maxillary sinusitis and or anomaly of maxillary sinus ostium. Origin. It arises from the maxillary sinus mucosa and exists via its natural or accessory ostium. So by now you know that on the lateral wall of the nasal cavity, okay, there is the opening of the here. Okay, so this is the lateral wall of the nasal cavity, and here you get the opening of the maxillary sinus. Okay, this maxillary sinus ostium is here, and lateral to this is the maxillary sinus, and along with the natural ostium, there are some accessory ostium around here. Okay, just behind that. So the polyp will grow out from there. Okay. So here in this pictures, you have seen that the polyp has grown out into the nasopharynx and subsequently into the oropharynx. So you don't see a large mass hanging out from the nose. Okay, so why does it go back? Okay, there are a few reasons for it to go back. Okay, so the reasons are, sometimes you may be asked, but this is a more important question for PG students. So maxillary sinus ostium is directed backwards, right? To make you understand, okay? So suppose this hole of the pin is the maxillary sinus ostium. Suppose if it is coming out, so and this is the maxillary sinus, okay? So if it is placed like this, then it will come outside the interior layers. But it is placed like this, so naturally it will go behind. Next is cilia, they beat posteriorly. In the first class, we talked about the physiology, and the cilia, they have the tendency to beat back, and also the nasal secretions, they are taken into the oropharynx because of that cilia beating posteriorly. All right, and as obvious, the air current flow posteriorly, but you may also say that the air current also flows anteriorly because we exhale that. But when we inhale it, there is the lamellar flow, and when you exhale it, there is the eddy currents. Okay, so because of the turbinates, they block the flow of the air in the way it has been flowing inside. So that is why this mucosa, by the action of the current, air current, they are taken back. And similarly, the nasal floor is sloping backwards. So by the action of the gravity, it will flow towards the nasopharynx and oropharynx. And similarly, any mass will grow where it finds the space. So posterior nasal cavity has a larger space, as obvious. So there is tendency for it to grow posteriorly. And similarly, when we swallow, there is negative pressure in the oropharynx, and that will also help to pull the mass in the oropharynx over prolonged time. Now, how do you diagnose the case? Okay, diagnosis is very important, and these diagnostic methods are quite similar between NC polyp and ethmoidal polyps. So, anterior rhinoscopy, that is a clinical examination. Okay, so what are the other investigations? So, you do the diagnostic endoscopy. So, you put a telescope or flexible endoscope in the nasal cavity and try to look at the different areas, and you can be, it will be very easy for you to see any mass if it is present there. So we do the, we can also order for X-ray PNS and X-ray of the nasopharynx and lateral view to look for the presence of air between skull base and bone. Okay, so X-ray, we do not prefer X-rays these days because the diagnosis is mostly made clinically and by the use of nasal endoscopy. So we usually send the patient for CT scan of the PNS. So this will help us, okay, diagnosis, not only to make the diagnosis, but it will help us to learn about the anatomy of the nose. Okay, it will help us to know where the mass is present and the other structures, the important structures in endoscopic sinus surgery, like the lamina preparatio, the position of the middle turbinate, uncinate process, all those things. So the CT scan will help us to guide through the surgery. So that's why we prefer to send for CT scans. Okay, so this is how diagnostic nasal endoscopy is done. So it is done under local anesthesia. Okay, we just give the xylocaine nasal spray, the 15% xylocaine nasal spray. Okay, right? And this is what you see in endoscopy. Okay, this is the right inferior turbinate, and this is septum, and here you see the nasal mass. Now, we do not prefer X-rays, but like you need to know. So in X-ray, look here, the mass is like this here, and here also there is some opacity, but there is some concavity. So whenever there is concavity, so it may be because of the fluid. Okay, but here is convexity. So because of the convexity, we feel that it is a mass. And look here, you see some soft tissue shadow in the oropharynx. So you suspect AC polyp. Okay, CT scan, a very good diagnostic modality. And look here. So this is the inferior turbinate, this is the bony part, and there is the mass filling the maxillary sinus coming through the ostium into the nasal cavity. And the subsequent slides will tell you the reason or the areas where it has reached up to or where it has grown up to, right? And this is the left side, and look, this is free here. Okay. Now the treatment modality. Okay, antibiotic is not for treatment, but it is only given in conjunction with surgical treatment. The treatment is almost always surgery. Okay, so because there might be nasal discharge and there might be sinusitis, so we can give a course of antibiotic and also during the surgery. So the operation is that we prefer to do is functional endoscopic sinus surgery. Okay, FESS. Okay, so if you must know about one surgery regarding the nose, so it is FESS. Okay, there are so many conditions where FESS is done, functional endoscopic sinus surgery. So I have a video of FESS, and I'll later on let the video do the talking. Okay, because it's always better to show than to explain. Okay, similarly, Caldwell lock operation. Okay, Caldwell lock operation. It used to be done frequently previously, but these days, we don't prefer it much because FESS is a better modality of surgery and it has lesser complications. Now, as with any polyps, a recurrence is coming. So, how do we prevent a recurrence? By complete removal of all the parts and wide middle meatus antrostomy. Okay, so the opening of the maxillary sinus into the nasal cavity, so that is called antrum. So it should be made wide. Okay, and we also need to give post-operative antibiotics. So and this is also very important for you. What are the different parts of the AC polyp? So in the books, you may be they have made a mention of the phrase. Okay, the AC polyp is dumbbell shape. Okay, dumbbell, dumbbell, the ones you have been using in the gyms and even at your homes. Okay, so dumbbell shape. So this is one part and this is one part, and here is the thin part, the connecting part. Okay, so A, C, N. Okay, so A for A is globular and it is present in the antrum, in the maxillary sinus. Okay, so the nasal part is flattened transversally. Okay, and similarly, the globular part, the quena is also globular. Okay, and the neck is present here at the maxillary ostium. Okay, so these have three parts. Okay, the anterior part, the quenal part, and the nasal part. And in the nasal part, there is a part which is the neck where it is coming out from the ostium. Okay, so there are three parts. Now, this is what I mean by antrostomy. Okay, the antrum is not so large in the naturally, but it has been widened so that it will help us to prefer. It will regulate the drainage of the nasal secretions and it will prevent recurrence. Okay, so this is the Caldwell lock operation that I just mentioned some time earlier. So we make an incision in the gingival-labial sulcus, and from there we will enter into the maxillary sinus, and we extirpate all the mucosa and take out all the mass or pathology from there. So now it's more polyp. So sometimes hear the word nasal polyposis, or you see that word mentioned somewhere in our OPD tickets or elsewhere. So by nasal polyposis, we always mean ethmoidal polyps, okay, or sinonasal polyposis. Okay, nasal polyposis consisting of multiple bilateral polyp is a part of inflammatory reaction involving the mucous membrane of the nose, the paranasal sinuses, and often the lower airways. It is a form of chronic inflammation of nose and sinuses that is a part of the spectrum of chronic rhinosinusitis. Okay, different sources they have different definitions, but the management is more important. So what is the clinical presentation? So it is mostly in the adult patients, and there is always bilateral nasal obstruction. Okay, and there is bilateral water nasal discharge, and there is excessive paroxysmal sneezing, and there can be history of previous nasal surgery, okay? Because allergy has been implicated in cases of ethmoidal polyp. Okay, so sometimes when we asked what is the etiology? So in one word, the etiology for AC polyp is inflammatory, and in ethmoidal polyp it is allergic. Okay, not always, but it may be. Now this is how the presentation looks like. Right? Okay, this is just a direct examination, and here we have put the speculum. So these are the blades of the speculum, right? And we see the mass here. Now another clinical feature is the broadening of the nasal bridge, because the polyp there tends to grow in this area. Okay, it doesn't go to the posterior choana, and it also doesn't come to the anterior choana. Now, this might be asked also sometimes. So what are the associated diseases? Okay, so if there is aspirin intolerance, bronchial asthma, and ethmoidal polyp, so it happens in Post-steroid. So ethmoidal polyp can also be associated with cystic fibrosis, with allergic fungal sinusitis, and with Cartagena syndrome, where there is severe dyskinesia and situs inversus, and in Young syndrome, where there is sinonasal polyposis with hyperviscous mucus and azoospermia. And then what are the investigations? The same, they are similar. Okay, diagnostic nasal endoscopy, X-ray of the PNS, and we always do the CT scan. Okay, we do not operate. Okay, we do not operate the patient on the nose without a CT scans, because CT scan is our guide to the surgery. We may not be doing it to diagnose the condition, because we might have already diagnosed it by examination only, but still always sent for CT scan. And some tests for allergy can be done. Okay, this is what you see in the endoscopy. Okay, look here. This is the nasal mass, and this is the nasal mass, and this is probably the turbinate. Look here, this is the turbinate, and this is how the mass looks like. Both the AC polyp and the ethmoidal polyps, they look like they are green color and they are glistening. Okay, so it is quite obvious. And this is the mucosa, the normal mucosa of the turbinate. This is pinkish in color. Okay, and look here, gray and glistening. Right? Okay, and again another endoscopic image. This is how it looks like. And in the paranasal sinuses CT scan, this is how it looks like, right? So what are the non-surgical treatment? Okay, there is something called medical polypectomy, right? But that is a misnomer. So when you say polypectomy or ectomy, so it almost always means surgery. So there's nothing like medical polypectomy. But in case of ethmoidal polyps, sometimes we can attempt medical therapy. Why? For two reasons. There are some patients who are unfit for surgery. There are some patients who are fit for surgery, but they do not want to go for surgery. And sometimes when the nasal polyp or the ethmoidal polyps, they are quite large. So we feel that the surgery will become easier if the size of the mass is decreased. So in such cases, we attempt medical therapy, and the response for medical therapy is also very good in sinonasal polyposis. But in AC polyp, medical therapy never helps. Okay, so the drugs that can be used are oral prednisolone and corticosteroid nasal sprays for prolonged time, and similarly oral antihistamines, okay, and allergens, they're avoided, okay. So only when, if the patient wants this medical therapy is a therapy to be therapeutic, so we need to tell them that only in small polyps it can be helpful, but in large polyps it won't be helpful. So look here, the patient has been given steroid, so it was pre-steroid image, and this after post-steroid, and you can see the cavity. Okay, there are no secretions, and the size has also regressed, and the cavity has become larger, and the patient is able to respire easily. But you should know that, and the patient should know that, so this will recur. Now, surgical treatment. So intranasal avulsion, the polypectomy, extranasal externalismectomy. Okay, these are different types of nasal surgery, but we do not do this these days. Okay, so what we do is functional endoscopic sinus surgery. Okay, there are different techniques for functional endoscopic sinus surgery. You do not have to go in detail. Okay, there is, but no these terms, conventional type, where we just insert the telescope, look inside, and we pluck out the mass, we take it out. And similarly, there is the micro-debrider. So the micro-debrider technique has been used very frequently, and this is a very good modality. The very good technique, and there will be less bleeding, and there will be, and the operation will become very fast. And similarly, lasers can be used. So look here, this is the telescope. The telescope is, and here is the light. Okay. The telescope is for illumination, and here this is the instrument. So this is how FESS is done. Now, functional endoscopic sinus surgery with navigation to locate the mass, the pathology intraoperatively. Now, this is the micro-debrider. Okay, the micro-debrider is also standing like this. It may be a forceps or it may be a micro-debrider. Right? Here it looks more like a forceps. So in the micro-debrider, the tip again it comes here. Okay, so this is the this is the tip of the micro-debrider, and this is the machine. Okay, and how this works, I have a video here.
The left side of the nose shows presence of extensive polyps. The right side also shows extensive polyps, with some polyps arising from the nasal septum also. The micro-debrider is being used to debride the polyps so that the anatomy can be much better identified. Damage to the adjacent mucosa is prevented because of the use of this instrument. One can continue to remove polyps under vision in spite of the bleeding because of the continuous suction effect of the micro-debrider. One can see very clearly how well the middle turbinate is being preserved in spite of extensive polyps. The debrider is now being used to clear polyps medial to the middle turbinate also. A window is being made in the uncinate process in the lower part. The remaining uncinate process is being debrided away very carefully. The agar nasi is in view. The maxillary sinus opening is now being widened by debriding away the polyps in this area. Polyps medial to the middle turbinate in the sphenoethmoidal recess are now being debrided under direct vision. The polypoidal middle turbinate is now being trimmed very carefully without excision of the middle turbinate. The anterior ethmoidal artery can now be identified crossing well below the base of the skull. Using conventional instruments while grabbing the polyps, one can land up with damage to the anterior ethmoidal artery. Hence, one must be very careful in removing polyps posterior to the frontal recess. The posterior ethmoidal cells are now being opened with the micro-debrider to reveal an onode cell with the optic nerve at its lateral boundary. The opening of the sphenoid sinus is now being identified. Polyps are now being removed from the sphenoid sinus. The sphenoid sinus opening is now being widened with the help of the micro-debrider to complete the operation.
Okay, that was the end of the video. So this video was shown to you to give you an overview of how a surgery or nasal surgery using the debrider or functional endoscopy sinus surgery looks like. Right? So that debrider, it has a tip, right, which has the blade, and it gnaws, like the rodents, when they eat into something. So that there is a blade that gnaws into the tissue, and then it also has suction that takes out all the mass inside the suction, and thus the disease is cleared, and all the openings, they are made large, all the sinus openings, so that there is no recurrence of the disease. Now, how to prevent recurrence? By complete removal of all polyps, avoiding allergens, and in case of ethmoidal polyps, so post-operatively we need to get oral histamines and corticosteroid nasal spray for a prolonged time. And this is how the nasal cavities, they look like. All the openings, they have been made larger. The constant opening, the maxillary sinus ostium, and the ethmoidal cells. Okay, this is how it looks like in CT scan after FESS. Okay, probably this is the last class, and okay, last slide. Okay, and this is also the most important slide of today's lecture. So, in not in the final exam, but usually in the terminal exams, you are asked about this, like the differentiate between ethmoidal polyp and the AC polyps, and you need to know all these points. Okay, more the points, the more marks you get. Lesser the points, the lesser marks you get. Right. So be careful here and just take a snapshot or write it down. So AC polyp, it is seen in adolescents and children, ethmoidal in adult. Etiology is infection here, and it is allergic. Okay, it is single. Okay, it is multiple, grape-like in bunch. This is unilateral and this is bilateral. Okay, the shape is trilobed, dumbbell shaped, and here it is grape-like, okay, in bunches. It grows backward. Okay, it grows forward, not backward. Okay, and here the treatment is always surgical, but here medical treatment. Okay, here also the treatment is surgical, but the medical treatment may be combined with surgical treatment. And recurrence is very uncommon. And in case of ethmoidal polyp, the recurrence is quite common because of its allergic origin. So this slide is the sum total of all the slides that we studied earlier. Okay, so I hope you are now clear. You are now clear with nasal polyps. Do you have any questions? Okay, that's a good question. How do you manage hypertrophied inferior turbinates? Okay, hypertrophied inferior turbinate can be physiological. Okay, suppose the patient has a DNS on the other side, then there is tendency for that patient to develop compensatory hypertrophy turbinate, inferior turbinate. So in that case, if you treat the DNS, then the hypertrophy turbinate can become smaller. Okay, you can also give decongestant, okay, systemic, or you can give local decongestant, like the oxymetazoline nasal drop. And if all of that doesn't help, then we can do the surgery. Okay, we can trim the inferior turbinate. Okay, so in the end of the class, if you have any questions, then you can ask me, or if not, then just I'll summarize. So what I want to tell you at the end of the class is that this is a common condition which is misdiagnosed and almost always overdiagnosed. So when you're in the periphery, try to restore provisional diagnosis. And if it is not AC polyp or something that requires surgery, so wrong counseling, getting operated, it will only it will only become difficult for us to further counsel the patients, right? So okay, then that should be the end of today's class, and in the subsequent class, we'll be talking about rhinosinusitis. Okay, after 2 days later. So okay, have a good time and stay safe.